So today we're going to talk about radiotherapy. We'll deviate a little from the book just because things have changed a little since when the book was first written. To start with, let's consider the 4 R's of radiotherapy. These are repair, repopulation, reoxygenation, and then redistribution. We'll talk about all of these 4 R's in turn. However, the first R, repair, is the most important. The reason why it's the most important of the 4 R's is because most of what we do involves repair and taking advantage of repair. Consider the DNA molecule. Recall from all the way back in week 2 that single strand breaks are usually repairable. They're repairable because all of the genetic information is on the other strand of the DNA, and so the cell can copy the information from the intact strand over to the damaged strand, and no information is lost. Double strand breaks are a different matter. If both strands are broken close enough together, then you potentially lose the genetic information. You get chromosome damage that can't be repaired. For high LET radiation, that is the high linear energy transfer, that's like the big bowling balls of radiation that can come in and cause lots of damage close together. Double strand breaks are more common, and we'll come back to high LET radiation later. When we're talking about low LET though, at low doses there is much less localized damage, and both strands will be unlikely to be broken at the same time. You'd expect to see more of the repairable single strand breaks, and we'll see later on why this is important for radiotherapy when we talk about fractionation, giving lots of low doses every day instead of just one big dose. But if we increase the dose, then more damage will occur, and it becomes more likely that double strand breaks will happen. The second strand will get damaged before the first strand has had a chance to repair the damage. That is why the survival curve gets steeper as dose increases. Let's look at a typical survival curve. Here is the log of the survival fraction as a function of dose. You can see it gets steeper at higher doses, and as the shoulder at lower doses. For cells that have a high capacity for repair, the curves have more of a shoulder at low doses, almost horizontal at low doses, before becoming very steep. In other words, the capacity for repair makes these curves curvy. Now, in radiotherapy, we have cancer cells and normal cells being irradiated at the same time. And obviously we want to kill the cancer cells and spare the normal cells. For some reason, cancer cells are not usually as capable of repairing damage as our normal cells, and that's why radiotherapy works. Radiotherapy would never work if the cancer cells could repair the damage as efficiently as our normal cells. This gives us a window of opportunity. The window of opportunity exists at low doses, or low doses per fraction. And this is why we give low doses in multiple fractions instead of one big dose. Consider the survival curves for normal cells with a high capacity for repair in green, and the red curve which is for the cancer cells. The normal cells have a curvier survival curve than the cancer cells, as normal cells have a higher capacity for repair. This gives a window of opportunity, which for these two curves occurs at around 2 grays per fraction, where the radiation kills less the normal cells and more cancer cells. For higher doses it would be the opposite, which is why radiotherapy works at low doses, or low doses per fraction. Let's consider what effect fractionation might have then on our survival curves. Each fraction has a lower dose, around 2 grays per fraction. And clinicians discovered this by trial and error, by treating cancer patients and seeing what doses worked. Now we can explain this in terms of the higher capacity for repair in normal cells, and the window of opportunity. At each fraction you kill slightly more acute responding cancer cells than late responding normal tissue, and the curves continue to divide with each fraction. We'll come back to this in a second, but let's just look at the role of fractionation. If we were to give a single dose, then the curve would get steeper with higher doses, and the survival curve would follow the first dashed line. However, at 2 grays the treatment is stopped and repair is allowed to happen. Then, when we apply the next fraction, instead of continuing down the steep curve for higher doses, we get another shoulder. In essence, the tissue can tolerate higher doses because of the fractionation. Here, after 4 fractions, 8 grays, which corresponds to a survival of 0.01%. But with a single dose, this surviving fraction will be expected at only 4.5 grays. Here's some survival curves for the same tissue but with increasing number of fractions. As the number of fractions increases, the curves move more towards higher survival, and the curves become more linear. At some point the doses are low enough at each fraction that double strand breaks really occur, and there is no quadratic part. Getting back to acute and late responding tissues, where tumours are considered acutely responding, the surviving fraction is much greater for the late responding tissue, as they have the greater capacity for repair. At each fraction we want to hit the sweet spot, to be exactly in the middle of the window of opportunity, where cancer cells are killed more than normal cells, so that the survival curves for the tumour and the normal tissues diverges as much as possible. Multi-fraction radiotherapy was originally based on experiments in the 1920s in Paris, where they really didn't understand the mechanisms at play. They found that with a single high dose of radiation, a ram could be sterilized, but would have extensive skin damage. The same dose over multiple fractions still sterilized the poor ram, but now it was possible to do so without damaging the skin. The testes are acute responding tissue and can be compared to the tumour in radiotherapy, while the skin is the late responding normal tissue. However, much has changed since then. In the above analysis, we've assumed some things. We assume that the dose was the same for the tumour as it is for normal tissue. Is this the case? Well, when the book was written 30 odd years ago, it might have been, but it isn't nowadays. Conformal radiotherapy uses CT imaging scans to map the location of the cancer in the body. Then, radiation is delivered from several different directions, and the beams can be positioned to shape or conform the regions of high dose to match the shape of the cancer. Here's an example where the radiation beams have been shaped to create a region of very high dose exactly where we want it, at the tumour. The dose is no longer the same everywhere, but can be heterogeneous. In other words, there are regions of high and regions of low dose that can be precisely controlled. The upshot of this is that the normal tissues effectively gets less radiation than the cancer tissue. We can administer higher doses to the tumour while the patient can tolerate the lower doses to the normal tissue. We define this, or we characterize this by defining the geometrical sparing factor to be the effective dose to normal tissues divided by the effective dose to the tumour. For conformal radiotherapy, it'll be less than 1, and the more conformal the beams, the smaller the geometric sparing factor will become. So what effect does this have on the window of opportunity? With just a small 20% sparing of normal tissue, or a geometrical sparing factor of 0.8, the two curves move slightly further apart. Note the scale on this graph is really quite large, so they don't look as far apart as they might have done on a smaller scale plot. And the window of opportunity also shifts to a higher dose. For conformal radiotherapy, it is possible to use much higher doses per fraction, called hyperfractionation, which should mean shorter treatment times and less expense. So, what is the upshot of all of this? Well, hyperfractionation schedules are being used right now, especially for prostate and breast cancer treatments, with cure rates and complications comparable to standard fractionation. Hyperfractionation is attractive in situations where resources are scarce, or it may be difficult for patients to undergo prolonged intensive daily treatments. Hyperfractionation is not really all that new. Brachytherapy involves placing the radioactive source next to the tumour and then removing it sometime later, which, when you think about it, is highly conformal high-dose radiotherapy. High-dose rate brachytherapy is used to treat prostate, lung, or breast cancer and involves inserting thin tubes into the tumour, sending a source of radiation down the tubes for a few minutes to destroy cancer cells, but before removing the radioactive material. The radiation is put directly into the tumour, sparing nearby healthy tissue.